Would you please welcome Mr. Jim Harenberg?
Thank you, Todd. Good afternoon, everybody. So I have about 12 or 13 minutes of time to hopefully capture your attention and talk a little bit about what the future outlook might be in the medicine space. And as I thought about opening my conversation, I reflected on the fact that many speakers will often draw connections to the theme of their talk by looking at an analogous situation. Many times they do that by looking at space exploration. This year has been the 50th anniversary of the Apollo mission landing on the moon, and I thought that would be an amazing way to start. But I'm a kid of the 70s, and I grew up with some different space exploration stories. And so rather than talk about a historic mission, I'd like to start our conversation from some lessons learned from Mr. Spock and Captain Kirk and the crew of the Starship Enterprise. Now, for those of you who may not be Trekkies like I am, you may not have caught that they have some very interesting value and morals discussions as a part of their TV shows and movies. And in one particular movie, The Wrath of Khan, a dilemma was laid out before the crew. You see, the crew was in danger, the ship was disabled, and Mr. Spock entered a highly radioactive chamber to fix the ship and save the crew. But in doing so, he sacrificed his own life. And as the movie goes, he's talking to Captain Kirk with his last breaths before he perishes. And he says to Captain Kirk, "The needs of the many outweigh," and then Captain Kirk finishes, "the needs of the few," to which Spock adds, "or the one." Now, spoiler alert, in the next movie, the crew realizes that Spock can be saved. And in order to do that, they have to focus on him putting the citizens of Earth in peril. And yet they do it. And when they save him, he then speaks to Captain Kirk and says, "Why would the crew do that?" And Kirk answers, "Because the needs of the one outweigh the needs of the many." Now, to me, that's a perfect analogy for the challenge that you as enterprise leaders, as HR executives, as financial executives in your firms are dealing with when we think about providing benefits and the potential impact that medicines and the growth in medicines may have. How do you balance the needs of the many with the needs of the few? And so throughout this presentation, what I'd like to do is help you understand where the future is taking us so you can be better consumers and weigh the balance and the choices that you need to make. Now, as we think about a situation like the Starship Enterprise, they clearly had a problem. So the question is, do we have a problem? Should we be worried? Based on 2018 data from IQVIA, which is an industry firm that monitors the prescription basis here in the US and around the world, they reported that the per capita average spend for drugs in the United States is $1,044 in 2018. And in their report, they said this is good news because since 2009, that per capita spend has only increased by $44. And in fact, as they project out for the next 5 years after 2018, they estimate that the trend will only be 3 to 6% growth over each of those years. That's good news, right? If that's the case, why are we all sitting in this room worried about the impact that prescription medicines may have on our bottom line? Well, the reality is if you dig underneath that per capita number, you see some trends that are concerning, that many of you, through your questions, are aware of. The biggest one is that specialty medications now account for $517 of that $1,044, almost 50%. And even more important is, since 2009, the contribution of specialty medications has increased by $255 per person, whereas traditional non-specialty medicines impact has decreased by $210, predominantly due to generic medications and a shift in the underlying system. So, do we need to be worried? Do we have a problem? The Pharmacy Benefit Management Institute surveyed large employers, and the answer to that question is 61% of large employers are worried. In fact, the number one priority that they set about through this survey was addressing the management and cost risk associated with specialty medications. And it's not just in the private sector. CMS Administrator Seema Verma, at a recent Future of Health Summit about 2 weeks ago, indicated that in her remarks, when the recent hepatitis C cure was launched in the US market. Some of you may have had to pay for that medicine over the last few years. It launched at just under $1,000 per year per patient. And yet she said, and I quote, "Now we have a $500,000 drug and a $1 million drug, and the question is, where does it end?" And later in the same talk, she said, "The system is not sustainable as is." Why is that? Well, part of the reason is that we have an amazing drug development pipeline in existence around the world. And while we may talk in many ways about the impact financially of medicines, the truth is they are important health tools in our healthcare system. And in fact, when you look at this slide, which shows data that's about 2 years old, I skipped one. There we go. When you look at this slide, which shows data that's about 2 years old, and I printed it purposely small so you can't read it, what you can see is that there are about 2,600 medicines in development from what's called phase 2 through phase 3 clinical trials. And of these medicines, as an example, the largest sector are cancer medications, 27%, or roughly 700 medicines. Now, as a patient, as a person whose family member has survived cancer, that is amazing to me. That innovation is amazing. But as an advisor to employers who are paying for health care, that is a very daunting number. Because typically these specialty medications come with a much higher price tag per person. In fact, in the US market, projections are that we should expect between 45 and 55 new medicines per year for at least the next 5 years. And as Todd mentioned in his opening remarks, many of those are expected to be specialty medications. To put that in context, over the last 5 years, 219 new medicines were approved in the United States. Now, to show you the slide that I inadvertently advanced to, that in and of itself is not necessarily a concern, because remember, specialty medications are a part of that per capita spend that I talked about. But what perhaps is a concern is another underlying trend, and that is the fact that within that specialty medication mix, we're starting to see more and more innovation that are considered orphan drugs. These are drugs that meet a different standard, and which we'll talk about in a minute. But to put it into specific quantified terms, of the 59 medicines that were approved by FDA in 2018, 39 were specialty medicines, 34 received orphan drug status. Why does that matter? Well, why it matters is based upon some important information about rare conditions and orphan drugs. Orphan drugs treat rare conditions. Rare conditions in the US are defined as a condition which affects fewer than 200,000 Americans. That's not a lot of people. The Orphan Drug Act was created in 1983 to help provide a financial incentive for drug researchers to invest in areas where the market size, whoa, I'm gonna fix that, right? You do not need me in stereo. Where the market size was smaller than other markets. And what we were finding was researchers were not motivated because they couldn't necessarily guarantee a return on investment by investing in smaller patient population sizes. And so in the 1980s, this law was passed. Now, since then, about 500 medicines have been approved. These 500 medicines treat rare diseases. But what's interesting is when you look across the United States, especially more recently with advances in genetic testing and other diagnostic capabilities, we've identified over 7,000 rare diseases. They represent an estimated 30 million Americans in total. The number of diabetics is estimated in America to be 30.3 million people. 10% of the US population of both groups. How rare are these rare conditions? For any one disease, for any one patient, they're very rare. But in aggregate, they represent a risk area that we need to be considering. What's interesting is in the current development world for the pharmaceutical industry and drug researchers, there's a lot more interest in these spaces, in part because the Orphan Drug Act creates an exclusivity in the market for a period of time that allows the drug company to get their return on investment. The price points that we're seeing for some of the new medicines are also contributing to that. In fact, when you look at the 500 medicines that qualified under the Orphan Drug Act and you look at their current pricing, The average price for an orphan drug is about $87,000 per year per treatment. Now, what's interesting about that is these are conditions that often require years, if not a lifetime, of treatment. When you look at the total impact on the health system, over the past 20 years, orphan drugs have grown from 4 to 10% of our spend, even though they represent only 0.4% of the total prescriptions. Keeping in mind that specialty drugs in total only represent 2.2% of our total prescription volume. So, specialty drugs are impactful. Orphan drugs are becoming impactful more and more every day. But the great news is there's some new science based on gene and cellular advances that are leading to even greater technology and improvement in our ability to not only treat, but now cure diseases. Now, I'm not going to get into the clinical side of this. We can have Dr. Miller do that later. But what I can tell you is, from an economic perspective, the advent of this era of medicine poses some interesting fundamental shift opportunities in the way we manage the economics of drugs. And here's why. When you look at this projection, you see that we may have between 40 and 50 gene or cell-based therapies enter the US market between now and 2030. These medicines tend to cost hundreds of thousands to millions of dollars because they do treat small populations, they are very complex, and the investment to bring one of these to market is very substantial. In fact, we have 2 recent examples that have entered the US market that we can look to for a bit of understanding. Some of you may have heard of Luxturna. Luxturna treats a inherited retinal disease that can lead to blindness. It can be cured with Luxturna for the price of $850,000. Another medicine, Zolgensma, entered the market for spinal muscular atrophy. It's a condition that an infant has that can lead to their death if not successfully treated before the age of 2. The price tag to cure that child, save a life, $2.1 million. Now, there might be some discounts and negotiations that you can incur, but chances are you're still talking about a multi-million-dollar expense. Here's the fundamental challenge. It's not just about the absolute price of the medicine. It's the fact that these are typically one-time treatments. Yes, they cure the disease, but the bill is due at the time the treatment is incurred. Instead of having a lifetime or many years to amortize that cost as a payer, you have to absorb that cost now. So, what are we doing about it? Well, one of the things that's been studied is the evolving impact that, as Prime Therapeutics, who did the study shown on the slide, termed the super spenders. These are individuals that cost $250,000 a year or more in drug cost alone. Now, these individuals don't represent a large part of the population. In fact, out of their 17 million covered lives, there were only 4,800 that fit into this category, or 0.028% of their population. So a fairly small number. Actually, the odds are higher that lightning strikes than you have one of these folks. But the reality is, when they looked at those 4,800 people, they cost the health plans that pay for their medications $2.1 billion in 2018. And that was up 63% from just 2 years earlier. It represented 8.5% of their spend, and they project that these individuals alone will end up costing about 15% of their spend over the next 5 years. So the question that we all need to wrestle with is, knowing that there are gene and cellular-based therapies, that there are orphan drugs that treat rare conditions, that there are specialty medicines that are very important to healthcare, but they're all coming into the market with an increasing cost, and in a population that in aggregate represents the same size of potential impact in the US as does diabetes. What do we do? Well, one question is, what have we done? And there's some interesting findings that have been captured in this study. It looks at private health insurance plan coverage for orphan drugs. And what surprised me although perhaps it shouldn't have, is that 70% of insurers in this survey offer coverage with no restrictions. None. No restrictions for an orphan drug. Even more interesting is when you look at non-orphan drugs, they actually restrict them more often. The reason for that, in my mind, is probably twofold. One is they're looking at the top 20 drug list, which is looking at total spend. The number of people times less expensive drugs is adding up to a big number that they're concerned about. And that's why they engage folks like me, because it's a problem here and now. The other reason that they're probably not worried about orphan or rare drugs, as an example, is they haven't been struck by lightning. And yet I would suggest to you that when you're thinking about the needs of the many or the needs of the one, it only takes one. It only takes one super spender for a firm that maybe spends $200,000 or $1 million to start to wreck your budget and to create challenges for you as a fiduciary to your health plan. So what options do you have? They're not magic, and we're going to talk more about various options from the perspectives of the members of the panel in a moment. We can allow coverage without restrictions. We can continue to roll the dice and hope that we don't get the one. Is that a good strategy? It may be for your plan. But we can also look at tools and resources that are available to us, the types of restrictions and guidelines, both clinical and financial, that we put in place on other medicines that perhaps should be considered now for these new and emerging high-cost therapies. We can turn to partners like our insurance partners and our reinsurance partners to help us. We can look upstream at folks like the industries that will be on our panel. Ultimately, some of us can make that hard decision to exclude coverage, but that doesn't come without risk as well. And in fact, as I close, I'd like to leave you with some important considerations that I think you all know. When we're talking about benefits of any kind, we always need to pull back and not just look at the financial element of our decisions. Because benefits are intended to be one tool that an employer uses to attract and retain talent, to create employee engagement. And yes, there are financial considerations that you have to manage. There may even be legal considerations that you have to manage, as an ERISA plan in particular, or if you make decisions to exclude access to certain types of treatments. But I would leave you with this thought. Perhaps all of those together are not as important as us, as executives, as leaders, as business owners, thinking through the personal and corporate value guideposts that help us make these decisions. We offer benefits to be a benefit to our employees. How do our value systems impact that? Which brings us back to our dilemma. The needs of the many, the needs of the few. How do we balance them? Can we balance them? Do we have to make a choice? Save one, but not all? Save many, but not the one? If you're a fan like I am of Star Trek, what you remember is that Captain Kirk is the master of finding the solution to the problem that people think is unsolvable. So my challenge to you as you interact with the panel, as you think about where we're heading in the US, think about the opportunity you have to help us find that balanced solution, that solution that solves the dilemma, so that the many and the few may live long and prosper. Thank you.